Morning. Assalamu alaikum. Thanks for the organizing committee and hope for you a good journey for the program today.
Bye.
My presentation is going to be about the usage of the antiplatelet treatment during Stemi cases. I'm going to talk about the indication and usage. Then I'll talk about two case scenarios. One with abciximab, the other one with tyrifibam. And we're going to touch on some nursing consideration. From indication point of view, in 2021 ACC/AHA guidelines, the indication was mainly for patients going under PCI with acute coronary syndrome. The usage of the GPIs was with a large thrombus burden, slow flow, or no reflow. And the 2023 guidelines, European guidelines, the usage was for the no reflow or a thrombotic complication during PCI. Which one is better, intracoronary or intravenous? There was a systematic review and meta-analysis in 2023, considering that using intracoronary during Stemi cases will give greater benefits and myocardial reperfusion, reduce occurrence of MACE and heart failure within a month. The second one, we did a study in 2013, which is showing the usage of the intracoronary reapproval versus the intravenous was showing less stent thrombosis and TVR in both category, acute coronary syndrome and stable coronary artery disease. As you can see, this is the platelets. We have two platelets. They're going to combine or aggregate together within the receptors available. We have the multiple receptors, as you can see on each platelet. We have glycoprotein 2B3A receptors, and which is going to combine together with the availability of the fibrinogens, making them self-aggregate properly. Now, the glycoprotein 2B3A inhibitor will take place at this level, and it will block the platelet from aggregation. The main two medication usage in our center was abciximab and tyrifibam. We'll tackle one by one with each case scenario. The abciximab is available as a 10 milligram and 5 mils concentration. The loading dose 0.25 milligram per kg over 1 minute and should be filtered before administration. The maintenance dose is 0.125 mics per kg per minute. The maximum dose can be given by infusion is 10 mics per minute, or which is equal around 17 mils per hour. When we infuse the medication, we have to make sure that it's connected to a filter with 0.2 or 0.22 microfilter. And there is no adjustment for the renal impairment in this abciximab usage. This is a case of Stemi. If you're a Stemi, the patient came from the ER to the cath lab, and as you can see, we have distally at the bifurcation clot, very well formed. What we tried actually to do some aspiration, multiple aspiration with the export catheters. And then after the export catheter was taken out, we did an angio. So what do you think about this? Any answer?
Supported the findings.
What is it?
Why to the dog? So going to fix it from the oil.
Yes.
One of the patients of the arterial was an scotch.
Exactly. So this is a spasm, right? Caused by the wire. Thank you very much for your answer. The patient actually was put on ReoPro, so we give intracoronary ReoPro and infusion. And we bring back the patient to the cath lab to do another angio for the patients, and this was the result. And you can see we have good distal flow in the RCA, especially at the bifurcation. Tyrifibam or Regrastat, as it's known, we have a concentration of 12.5 milligram and 50 mils as a bottle, and there is a premixed Agrastat prepared already by the company. The dose administration depends on the renal function. Is it normal or abnormal? If you have renal function with a good normal renal function range. So the loading dose will be 0.4 mics per kg per minute over 30 minutes. With the renal impairment, we go to the half dose. Maintenance will start with the 0.1 mics per kg per minute for 12 to 48 hours. With the renal impairment, we go to the half of the dose. High loading dose was being practiced, and usually with the loading one, we give 25 mics per kg over 3 to 5 minutes. No adjustment if there's any renal impairment, since it's the bolus dose only, but the maintenance dose will be decreased, so we start with the 0.15 mics per kg per minute up to 18 hours. If we have renal impairment, we go by 0.75 mics per kg per minute. This is a case of patient who came from the ER. Actually, it was a late presentation, but she was having chest pain. So as you can see, we have a lesion at the LAD part, proximal and the mid segment. Sorry. Yes, 2 spots. And the RCA, we have a clot at the ostium part of the RCA. But as you can see also, the RCA is getting collaterals from the left system. The patient actually was hemodynamically stable, so he was actually referred to the multidisciplinary team discussions. The plan was for CABG. The patient refused totally the CABG, so the plan was to go for PCI to LAD. So we proceed for the PCI to LAD. This is the first shot. And then this is the final result for the LAD with the 2 stents has been deployed, proximal and then the mid segment. Then they try actually to attempt for suctioning the clots in the RCA in order to give it some trial, maybe it's going to work. So they did suction with the penumbra suction catheter, and then after that we did some ballooning, and this was the result. As you can see, we appreciate that we still have clots and we have diseased artery from the proximal part all the way down to the distal part. So the decision was actually to put the patient on agrastat for 12 hours, including heparin infusion, and bring the patient after a few days. This is when they bring the patient back to the cath lab. As we can see, we have some disease at the proximal part of the RCA with the clot availability as well. So we did attempt for ballooning. A stent was deployed. And this was the final result after stent deployment. From nursing consideration point of view, I would like to say that this medication actually, they are considered as high alert medications and requiring independent double check. The reason for this one actually because if you misuse those medications, it can cause harm to the patient. Overdose can cause more thrombocytopenia and bleeding. So which has to be taken in consideration in the cath lab and a very crucial part. The second thing is we need to observe for any signs of bleeding. The next one is about the blood test has to be taken in consideration, especially the platelet and the hemoglobin. From a sheath removal point of view, if we are removing the the arterial sheath manually, we need to apply more pressure to achieve a better hemostasis for these patients. So maybe for the regular sheath, we have an ACT within the range, so we're going to apply for 15 minutes, but this can take at least 30 minutes to make sure that you have a good hemostasis. The release of the radial compression device, nowadays the trend is to go toward the transradial axis. So for the transradial axis, actually, we did face some problems with the release of the TR band at the hematoma, especially if the patient on glycoprotein 2B3 inhibitors. So usually what our practice was 1 hour after the initiation of the TR band to release it. But we extended with those cases and those patients to make it 2 hours release instead of 1. And it did help actually to decrease the risk of bleeding. The forearm hematoma guidelines, since we start to have some complication with the radial one, it was the best practice to deploy and apply some guidelines, which did help actually to control those bleeding. We cannot stop the complication, which is forearm hematoma, but at least we can control it in a better way when we have a guidelines. And this has really helped us a lot in order to teach the nurses in the units how to control and how to manage the hematoma, forearm hematoma. Remember, drugs with AB in their names block glycoprotein 2B3 inhibitors like abciximab and tirofiban. Thank you.